I've always had an interest in public health, and it always amazes me that the importance of public health is underappreciated, particularly by conventional medicine. I'm going to give a quick background to the topic of social determinants, because they're often not fully understood. And then I'll quickly go through the recent research, and Dr. Dion was part of that. So, I hope you're all well. But I'll bet you, if you hopped out of bed this morning feeling well, I bet you didn't ask yourself why. If you got out of bed feeling sick, you would ask yourself why. But we don't ask ourselves why when we're well. But if you think about it, it's much better to know why you're well than to know why you're sick. It's much better to apply things that keep you healthy rather than to wait until you're sick and suddenly think, oh, crikey, maybe I better stop smoking. If anyone smokes here, please excuse me. I just use that as an example. So one thing is that this topic is underappreciated. We're not talking about a fancy drug that costs millions of dollars and gives you 6 months more life. It's far more important than that. This is a graph of outcome life expectancy at birth in America over the last century. Over the last century, the American population now lives 30 years longer. Not a few months, 30 years. Every year, it's not completely linear, but good enough. Every year, a baby born this year will live 3 months longer than the baby born last year. Why is that? It's like magic. If you have a sibling who's 10 years older than you will live 3 years longer than that sibling just because you were born later. You have the same social determinants, mum, dad, education, everything. Why is that? While everybody on that line got better, white males, white females, black females, the important thing here I would like you to realize is that the social gradients, that is between white and black, rich and poor, they don't go away. Poor don't catch up with rich. Everyone does get better, but like Orwell said, everyone's equal, but some are more equal than others. And those some are, unfortunately, the rich people. And don't think that this is knocking anyone south of the border. Canada's exactly the same. You can superimpose First Nations health, males and females, onto that graph. It's exactly the same. A First Nations male in Canada lives nearly 10 years shorter life than a non-First Nations female. And as time passes, disease passes. So this is for New York. At the top there in 1900, New York was a dangerous place. People died of pneumonia, tuberculosis, diarrhea, no different to any poor country today. And those have been replaced by heart disease, cancer, and stroke. But the important thing to remember is that social gradients still exist. Social gradients are like magic. They exist. It doesn't matter if it's infectious diseases or non-infectious diseases, the rich will do a lot better than the poor. So you might say, well, it's all pretty obvious. It's money. It isn't obvious. It is not a linear relationship. It's a complex relationship. You could study your entire life just the relationship between money and health. I plotted this from the WHO website, and on the bottom axis there I put GDP per capita. You could put income, it doesn't matter. And on the y-axis is life expectancy at birth. This is a two-part graph. In the first part, you buy health. As you get more money, you have clean water, you have food, you have access to health care, your kids go to school, the country generally gets a bit better. And round about the top, the angle there, you get to, I don't know, somewhere like Jamaica. People live low 70s. It's a pretty peaceful existence. You don't do too badly. That corresponds to an income about $10 a day. Once you turn the corner, all bets are off. It's a completely different relationship. Cuba has 1/10 the income of America, and yet Cubans live longer than Americans. How do you explain these things? Greeks live longer than Americans. Portuguese live longer than Americans. Why is that? It doesn't matter what you plot either. At the top there's under 5 mortality rate, at the bottom is maternal mortality rate. It doesn't matter. The relationship between health and money is exactly the same no matter how you do it. So in the poorest countries, income is directly related to health. You get more money, you buy health. In rich countries, it is completely different. It is the spread from richest to poorest that has greatest impact on, and you're probably sick of hearing this because it's a rather political time, and people do start aping these terms they don't really understand. But you'll hear all sorts of people twittering on about income inequality. What they're talking about is the ratio between the income of the top 20% over the income of the lowest 20%. So at the top right there, you see USA, 9 or 10 times difference between the income of the top 20 and lowest 20. At the bottom left is Japan, which is more like 3 times. And that is almost a straight line relationship with health. You can draw this exact same graph for America. If you do the same calculation for the individual states within America, you get an almost straight line relationship. So there's something about income inequality and health. That obviously doesn't really apply to poor countries. But it's obviously not easy. These are infinitely complex problems. This is infant deaths per 1,000 births per year in the United States by ethnicity. On the right there, the highest death rate is amongst African Americans. Next is American Indians. Next is white Americans. But at the left there are Asian Pacific Islanders. They are, as a group, the lowest income group in the United States. So they should be to the right of black non-Hispanics. But in fact, they're to the left and have the lowest infant mortality in America. Why is that? I have not got the faintest idea, and my only excuse is, of course, nobody else does, except to ape the obvious point that there's an awful lot more to health than simple money. It's important, but it's not everything by a very long way. So then you'll say, well, healthcare. Obviously, we're healthy because of healthcare. This is a big, big mistake. Healthcare is not the reason that we're all healthy. The reason we are all going to get through today without catching cholera or TB has got nothing to do with VGH, which is just a couple of miles up the road. It's very nice to have access to healthcare. If you get clogged by a car, you get appendicitis, it's wonderful. But in your day-to-day health, healthcare is not the thing that keeps you healthy. This is a perfect example here. You could draw this graph for any infectious diseases. This is the mortality from tuberculosis in Britain over the last century. And you can see from 1900 to 1940, the death rate from tuberculosis fell like a stone. There was no treatment. It was nothing to do with us. It fell every year. Treatment for tuberculosis didn't come in until 1945. And even then, the rate of decrease didn't change at all. And you can see from the 2 peaks, those are the 2 world wars. So tuberculosis is a social disease. And the biggest determinant of how you did with tuberculosis was whether there was social chaos. It had nothing to do with treatment. So people might say, well, fine, okay, healthcare isn't what keeps us alive. But healthcare certainly will reduce the gap between rich and poor. So if you make healthcare free, it means the poor will now have healthcare, and their health outcomes will become the same as the rich. So you just look at a big social experiment, which is the National Health Service in Britain in 1948. Healthcare is free to everybody, absolutely free to everybody. Here's a report by Lord Black in 1982. It's quite difficult to get these results because it was in the year of Thatcher's government, and she suppressed the results because it was a little bit too left-wing for her. But anyway, the Black report came out. If you look on the left there, those are the 5 social groups defined in UK. At the top there is the poorest, and at the bottom there is the richest. Over the 25, 30 years of this report, you can see that the trend is downwards. Everyone got better over that time period, but the difference between 5 and 1 got bigger, not smaller. So that doesn't work. Why? I haven't got the faintest clue, I'm sorry. But if you think that healthcare is a solution for health disparities, I'm afraid you're dreaming. It's great to have it. Don't think I'm arguing against health. It pays my bills. But don't think that on a societal basis, endless investment in health is going to be repaid by endless improvement in population health. So where does social inequality and population health fit in? Every keen observer of society understands that it's not good to be poor. Dickens obviously understood it. If you prefer the French literature, Victor Hugo is exactly the same. Social reformers knew it. This is a report by Chadwick, who was a big friend of Florence Nightingale, over 150 years ago. He shows the blue, the gentry, always lived longer than the purple, the tradesmen, always lived longer than the yellow, which is the laborers. It changed from place to place because some of these places were Liverpool and Bolton in the terrible, dark, satanic mills of Victorian England, but there was always a social gradient, and always has been. Medicine has been terrible, absolutely terrible at this. Medicine's approach, until fairly recently, was always, if you are sick, we've got a pill for you. It has some relevance, but it's not everything. The first time this was really tied down scientifically, it was called the Whitehall Study. Whitehall is the center of the British civil service. At the time of the study, everybody employed by the British civil service was a white man. There were no differences. They were all white men. They only differed. They all had houses, they all had clean water, they all had food, they'd all been to school. They all had access to the necessities of a healthy life. The only thing that they differed by was their position in the social class of the civil service. They were cleaners, or they were administrators, or whatever. There was a 4-time different mortality between the lowest people on the pole in the civil service and the highest people on the pole. It is completely unexplained. That has been reproduced 100 times since then. And it looks as if wherever there is a social gradient, there will be a health gradient. Nobody understands it. It is not smoking or drinking. Those are all statistically weeded out. Most of the difference in outcome between these people was simply, perhaps, the degree of control they had over their lives. Nobody knows. And on the right of that graph, the Whitehall 2 study, they just followed these lads up 20 years later, and those social gradients persisted. So this is important. Wherever there is a social gradient, it doesn't matter if you're a general versus a corporal, it does not matter. If there is a social gradient, there will be a health gradient. And don't think, again, that Canada is immune to this. This is a very recent study of the excess mortality caused by being poor in Canada. So if you look there, the relative RR stands for the relative risk. So on the female column there, if you're a woman with cardiovascular disease, you have a 50% higher mortality just because you're poor. Just because you're poor. Cancer, if you have a woman who has breast cancer, you have a 30% higher mortality simply because you're poor. If you have diabetes, 2.5 times mortality. Respiratory disease, twice. If you have HIV/AIDS, you have an 11 times higher mortality, 1,100%, just because you're poor. I know it's a political time of the year, but please do not be worried. I'm not about to enter into a harangue for my popular party. But you cannot talk about this subject without mentioning the government, because the government is the only one that's big enough and rich enough to actually level the playing field and try and get the poor people up. The Black Report, again, showed this exactly as Chadwick showed. On the left there, social class 1 is the poorest. I beg your pardon, social class 1 is the richest, and social class 5 is the poorest. And the mortality of those children is almost twice as high in the poorest than in the richest. Canada can be very proud. I'm sure you know the Lalonde Report in 1974. Canada was the first country to formally say the health of the country's populace is their business, not ours. The Lalonde Report says, fine, we'll build your hospital, we'll give you a police force and all the rest of it, but you've got to take part in this partnership too. And it's the first time the government said, you've got to stop smoking, you've got to stop drinking, you've got to take a run, you've got to keep your weight down and all the other things. And it was the first time that the government said, your health is not our responsibility. He was heavily criticized, I might add. So these are just very minor issues, examples, where a government policy has been designed specifically to help the poor. Minimum wage, rules about working conditions, welfare laws, childcare allowance. There are hundreds of these. But social legislation, and again, I'm sorry to sort of sound what sounds like almost a political harangue, but social legislation is an essential part of health. So I pinched this diagram from the Lancet, not because I think it's a good one. It just shows the cacophony of variables that go into health. It doesn't matter if you've got governance, social norms, biological factors, personal behavior, social cohesion, who knows? You churn all of this lot together and it spits out your health. So I'll just show this again, because honestly, I wish I could say something more sensible than it sounds like magic. But social health gradients are independent of disease type. In Victoria's day, if you caught TB, you would die at a far higher rate than if you're rich. When it turned into cancer and stroke, that social gradient is exactly the same. So social gradients are independent of disease type. They're also independent of healthcare. So what can you do about them? How can you stop rich people from, you don't want to stop it, you want to lower the rich, you want to raise the poor, but how do you level the playing field? I'm trying to find a cliche that is slightly less irritating, but the blasted phrase is actually useful. The poor old poor people are down this end, and you wish to level this playing field. And I'm quite sure everyone agrees, surely a good definition of a fair society is one where the health outcomes of the poor are the same as the health outcomes of the rich. And that is not true here or anywhere else. So we studied this in British Columbia because we have a nice closed population. So we looked at the effects of adverse health social determinants upon children who have chronic health diseases. I think reasonably, that if you have a chronic health condition, the effects of adverse social determinants are going to be somewhat magnified and easier to measure. So we looked at children with type 1 diabetes, children with cystic fibrosis, a congenital lung disease, and chronic kidney disease. And the measured social variables, there are hundreds of measured social variables, but we looked at 4 big ones. We looked at their access to healthcare. The proxy for that is just a straight line relationship, a straight line distance to their clinic, total family income, education, that is the highest education of the primary caregiver, and ethnicity. And so we measured those social variables, plus a bunch of other stuff, and we then measured the stable health of the child. So in cystic fibrosis, we measured their lung function. In type 1 diabetes, we measured an assessment of how stable their sugars were. And in chronic kidney disease, we measured the progress of their glomerular filtration rate over the previous 2 years. Is it going up, down, or stable? So in BC, we got everybody. We got all 96 children who have chronic kidney disease. We got all cystic fibrosis children who can do lung function tests. And we got a bunch of diabetics as well. So this is the main results for chronic kidney disease. Top left there is ethnicity. And you can see in GFR, the average change of GFR over the previous 2 years was 0. And there was no difference by ethnicity, including First Nations. Numbers are not that great, but as far as we could tell, there was no ethnic difference, which I think is a thing that the healthcare service can pat itself on the back about, because this is not true everywhere, I can tell you that. It also was the same for immigrants, and it was also the same for the couple who were refugees. There was no difference, again, with distance to subspecialty care. There was access to health care in Canada is excellent. Some people came even further than 1,000 kilometers, 1,500 kilometers, and their health was as good as people who lived around the corner from the hospital. Where there were significant problems were on the lower two. On family income, on the left there is less than 25,000 a year, less than 45, less than 65, and more than 65 on the right. If you look at the children in families that earned less than 45,000, their GFR was significantly different to the rich children. Children with chronic renal failure, even in BC, do worse if they're poor. We don't know why. What are the endless effects, adverse effects of poverty? We don't know. But the observation and the statement holds. If you are poor, you will not do as well as if you are rich. And on the bottom right, there is caregiver education. So the first left is did not graduate high school, then college, then university, and postgraduate. If your primary caregiver didn't finish high school, that child's renal function is worse than all of the others, significantly worse. It's interesting to see that all you have to do is make it to high school. More than high school doesn't make you healthier, but high school teaches you enough to keep you healthy. So if you summarize all the 3 groups, at the top there's chronic kidney disease. The ones less than 45,000 the children have worse kidney disease. In cystic fibrosis, the ones less than 45,000 have worse lung function, and it's slightly the other way around on the bottom one. On the diabetes, the ones less than 45,000 have poorer control over their sugars are higher than on the right, where the sugars are tighter. It is clearly shown that in BC, poor people do not do as well as rich people. And here's the summary, too, for the three groups for caregiver education. At the top there, the children of primary caregivers who didn't finish high school do worse than all of the others. In cystic fibrosis, only one hadn't finished high school, so we couldn't measure that. And then the bottom there in diabetes, it's exactly the same as before. If a primary caregiver didn't finish high school, the control of the diabetes was worse than amongst the other groups. So low income and poor education are associated significantly and clearly with poorer outcomes in children with chronic diseases in British Columbia. Ethnicity and residence have no effect on outcome. So subspecialty pediatric care in British Columbia is as good as it will get. It is fantastic. Dr. Dion and her team do a fantastic service for children with chronic kidney disease. But you're kidding yourself if you think that Dr. Dion running around in tight circles is going to make any difference to major social dramas. This is a much better diagram. There are hundreds of contributors to our health, and those are not all going to be treated by 3 clinic visits a year. Just one example, the monthly food cost for a family of 4 in BC is about $1,000. So if you're less than $45,000 income a year, you've got, $2,500 in your pocket after taxes. So if you've blown $1,000 on food, you've got something like $1,500 to keep a roof over your head and have a transport. I mean, it's nothing. Dr. Dion is not going to solve that. So, lack of caregiver education is a challenge, but it is relatively uncommon. It is a major challenge when it exists, but it is uncommon. The principal problem that we face at Children's Hospital is poverty. The children of families who are poor do worse, and that's not right. Inequalities between the rich and poor can only be dealt with. They're multifactorial. They can only be dealt with by groups of people coming together and attacking the problem at different levels. And so you need groups like this, who have a special interest in kidney diseases, in combination with the medical team, who understand the medical side of the problem, plus the unavoidable necessity to include the government. And groups like that, if they sit together, I do think slowly, social determinants, social inequalities can be chipped away at. But don't kid yourself that it's an easy job, because fundamentally, at the end of the day, we do not know. We do not know what it is about poor people that makes the outcome of their children worse. It's real, certainly exists, but why is it? I don't know. But it is something that we should, I believe, all attack vigorously. Thank you very much.
Hi. Thank you for a really stimulating talk. A couple of thoughts, questions came to my mind when you were pointing out the last slide set with the prognosis. Do you collect any nutritional information on any of these children?
I mean, it's obviously a very relevant question. I think one can only look on this really as a sieve, a course sieve. First of all, prove, beyond any shadow of doubt, the common understanding, but prove it, that poor people do worse than rich people. And that's what we set out to do here. You then got to grab that particular single problem and try and analyze it. So you then have to analyze, you've got to grab all the poor people and compare them to rich people, and now start saying to yourself, well, what is it? If it's just nutrition, well, do you say to these people, you give them a food grant? Is it something else we don't know about? I don't know. But it's something that, you give it some thought. I'm sure you'll be able to sort it out, and we will do that. But no, we didn't. The true answer to your question is no. But the real answer is that we didn't do it because the first one, you've got to do quite a lot of work simply to prove to everyone's satisfaction that poverty is not good for you. Down the road, you could say, why?
On a similar note, is there any look at adherence to therapy, whether prescriptions are filled, if they're covered?
Yes. Again, the answer to that is exactly the same. You might say, poor people may not have the time or the energy or the understanding or the whole bunch of things you can imagine, and they don't take the drugs as often and as reliably as rich people. That may well be a big part of it. Is it nutrition? Is it just what was shown in the Whitehall study, which is 80% of that difference between the social classes was unexplained? Some have said that that is just chronic stress, that if you're at the bottom of the pile, you're constantly irritated. You see people are richer than you, happier than you, have more control over their life than you, and you're just always annoyed. And although it sounds a bit silly, there may be something in that.
My last question, if I may just have one more. Do you know if there's a change, other than perhaps obvious trends for infectious illnesses, in the causes of child mortality since the Lalonde report in 1974?
Again, it was at the level of this exists, not at the level of why. If you sit down and say, why has this poor child, I don't mean poor, I mean economically poor child, why has this child died? Analyzing that and saying, would he have died if he were rich? You could spend your life answering those questions. Social determinants are complex.
It was self-declared income?
Yes,
Yeah.
yes, self-declared income, yeah.
I could probably just make a couple comments from what we do in clinic. So one, I think, as far as the medications, adherence we can't deal with, but we're fortunate being part of the renal agency where those medications are provided free of charge and delivered, so that there should not be barriers to getting access to the medication. So I think we're in a unique situation here in that hopefully should not be it. We can't put it in their mouth, but everything else up until that point is provided courtesy of renal agency and all the programs that have been established. So that's amazing for our population. A couple of comments about the nutrition in that we do have our dietitians with our clinic, and they do food records and food recalls. And what has made me reflect with some of these study results is that not only the costs of the food compared to their income, but the quality of the foods that we're asking to get on a renal diet are not the inexpensive ones. The foods that we're encouraging them to get, but these fresh foods that maybe are not available half of the year because of roads or access or what foods are available in certain parts of the province are a big issue. And what's easy is those salty boxed foods and things like that. So one solution I don't think is going to work for everyone in the province when we start thinking about how to improve the nutritional point of view. So those are just my comments. My question for you, Mike, is identifying these people. So we did the study, and I don't know who's linked to whom, but I don't know that even in our clinics we're great at identifying. We can identify them if they're asking for help, and we know that we have to help them with travel costs or food vouchers while they're with us. But I don't think we're good at asking. Do you have any comments on helping us figure out?
I've just finished another study on quality of life in children who are on home ventilation, and also on their primary caregivers. And it is impossible to tell. The social cues cannot tell you who goes home and sobs themselves to sleep. It cannot be done. And it's independent of money, by the way, and education. Some people are unhappy and some people are not. Some people are happy. And the only conclusion we came to is you've got to ask them. You have got to not allow the clinic visit just to concentrate on the child. You have to drag the caregiver away, and sometimes I really do mean that in that melodramatic way, and say to them, and interview them separately, which we do in home ventilation, and say, you know, how are things? And people will burst into tears when you... It's very sad. It really is sad.
And I guess my final question, and I know you're trying to avoid the political part
I am,
of
actually,
the
yes.
conversation,
God.
but most politicians have their 5-year policies, and this is not something that's going to be fixed in that time. So how do we advocate that this is a regular and recurring issue?
I am a little bit anxious about politics. You get people starting to throw things at you. But whether you are at the left or at the right, please excuse me making these political comments, but you will never find a right-wing pediatrician, ever. Because if you're a pediatrician, the care of the caregiver, the family's state, is an integral part of your day-to-day work. And you cannot sort that out with nutty right-wing trickle-down therapies. Please excuse me. I think I have gone far enough. But if your worldview is predicated on making the rich people rich, and their small change will filter through the cracks to the poor people, I can only say you must believe in Santa Claus. If you want the poor to be raised, you have to direct care at the poor. That is the final political statement I'm going to make. Please excuse me, but these things have relevance, so thank you.